hopefully I will provide a little bit or additional information on the way the rehabilitation or physiatrist approach to cerebral palsy. I have no relevant financial disclosures. Some learning objectives are to really describe and define cerebral palsy, the diagnosis, the classification schemas, some ideas about current physiatrist management, and then identify some management resources that for children with cerebral palsy. So thinking of definitions, so as Dr. Livingston discussed, cerebral palsy is the most common condition in pediatric rehabilitation clinic. A case example that I describe here is a 2-year-old who comes in, noting frequent falls, they're toe walking. There's no history of any prenatal events or concerns. The postnatal course was uncomplicated, but perhaps the child saw a neurologist, or perhaps the PCP, given the concerns, ordered advanced imaging, and we find that on MRI brain that it shows periventricular leukomalacia, so an evidence of an early injury to the developing brain. And the clinical exam seems consistent, where there's lower extremity spasticity or impaired motor movement or coordination in the lower extremities, whereas the upper extremities are behaving normally. And so this clinical picture is consistent with the diagnosis of cerebral palsy. And the definition I like to use is it's a group of permanent disorders of development of movement and posture, causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal brain. And so that's what was kind of shown in the initial case. What's important to recognize is that as Dr. Livingston had suggested, that it is, although it's a non-progressive injury that occurred to the immature brain, that the clinical picture is not static, and it does evolve over time, and that you can see changes in function in these children as they go through growth periods and as they go through the years of childhood. MRIs may be helpful, but they don't always, they're not necessary for the diagnosis, and they don't always show abnormality. Thinking about early signs of cerebral palsy. So as I mentioned, classically, the cerebral palsy is diagnosed around the age of 2, but there can be evidence and signs even earlier. So things like poor feeding and growth, which may be due to the neuromuscular hypertonicity that leads to higher energy needs, paucity of movements or asymmetry of movements on one side of the body or the other. Early handedness also goes along with that. Reaching for things, exploring its child's world on only one side. Delayed developmental milestones, abnormal tone, precocious development, such as, the child was an early roller, or look how good my child stands because they have extensive extensor tone into their lower extremities, so they can prop up to stand really early, which may all be evidence that there is something abnormal to the developing CNS. The classification schema. So there are a few ways to describe a child with cerebral palsy. Here is a diagram of body regions. So hemiplegia describing one side of the body that is affected, both the upper and lower extremity. Diplegia being both lower extremities being affected. Quadriplegia, all 4 extremities. Monoplegia just being one limb, either the one upper or one lower limb. Triplegia being 3 of the 4 limbs, and then pentaplegia kind of describing both the appendicular skeleton as well as the axial skeleton being involved by spasticity or dystonia. You can also describe a child with cerebral palsy by their movement pattern. Here you see 4 different movement patterns: spastic, dyskinetic, ataxic, and mixed. Those movement patterns also may correlate with the areas of the brain that are injured, where you see spastic being a cortical injury, dyskinetic having an injury to or an abnormal development to the basal ganglia deep brain structure, ataxic having injury or abnormal development of the cerebellum, and then a mixed athetoid movement pattern may have multiple areas of the brain being impacted. The majority of children with cerebral palsy are described as spastic, over 80% of the cases. And then, as Dr. Livingston spoke about as well, one very common used tool is the gross motor function classification system, which describes children with cerebral palsy based on their level of function, where children with a GMFCS level 1 being those who are most independent, most able to do varied pace of gait, varied terrain, to be able to ambulate upstairs without the need of any assist. Those GMFCS level 5 being the most dependent in their mobility, and then levels 2, 3, and 4 increasing in their needs, as sort of described in the pictures, needing some assist by handrails, GMFCS level 3 being able to propel with modified assistance, either propel their own wheelchair or use a reverse walker. GMFCS level 4 are more therapeutic walkers and need more support in standing and walking to be successful, but may be able to independently utilize a power wheelchair. So management and interventions. So having rehab early makes a start, and having the diagnosis of CP is not is not where we leave the patient or family. It's an ongoing discussion, and really focusing on identifying a plan for early intervention, empowering parents and children to really maximize their function and functional goals, and to remain active and successful through each stage of life, through community resources and with an interdisciplinary team. This diagram just kind of describes how interdisciplinary these children will benefit from, including orthopedic surgeons, neurosurgeons, physiatrists, the primary pediatrician or family medicine doctors, neurology, nutrition support, therapy services from PT, OT, and speech services, assistive technologies, social work, all blanketing the child to maximize their functional output. When it comes to management and treatment ideals, the schema that I commonly use is a sort of laddered tier or runged approach, where I'm thinking about the least invasive intervention as much as possible before advancing to more invasive interventions. And so we'll talk about each rung of this ladder in kind, first starting with therapy, modalities, bracing, and equipment. And so therapy, one huge resource for California for children needing early intervention and therapies is for early intervention, the regional center, and then for which children can remain in up to the age of 3. And then once they age out of the early intervention services, the California Children's Services Medical Therapy Program can be very, very useful in providing PT and OT services for a child who has the diagnosis of cerebral palsy. The medical therapy program works closely with kids and families to make sure that they have support in school and in the outpatient environment to think about bracing and equipment for these children. And they partner really closely with their referring providers and me as a physiatrist. It's important to note that anyone can make a referral to CCS, whether that be a school teacher, a social worker, parents themselves, or providers. As I mentioned, cerebral palsy, though a static injury, does the clinical picture of it evolves over time. And so thinking about management principles for infancy and early childhood, really focusing on motor and cognitive development, acquisition of developmental skills, thinking about feeding and nutrition, as I mentioned, because of hypertonicity and poor feeding, these kids can have need nutritional support. Spasticity management, contracture prevention, and musculoskeletal deformity prevention, which goes along with hip and spine screening, which Dr. Livingston spoke a bit about, and then adaptive equipment to support a child into their next steps of developmental skills. Some therapy modalities that are utilized in this early childhood may be casting, which you can see in the lower right-hand picture, compression, which is in the upper left, and then casting and constraint-induced movement. And so the ideas of compression and casting and constraint are all to limit the use of the unimpaired limb and really promote the use of the more impaired limb, so that learned disuse doesn't set in for the child as they are learning to do new things and new tasks. Taping, which is in the upper right, helps to promote movement patterns that are more normalized and that perhaps due to spasticity or tone, a child may have more difficulty with. Next, we'll talk about orthotics and bracing. So reasons for bracing include alignment to prevent deformity, to manage contractures, to promote motion in the typical range of motion or typical movement patterns, and also to conserve energy, and which all bring about improved function. And also bracing can help with pain control and to prevent limbs or joints from going through range of motion or movement that is unnatural to them. Bracing is named for the joints that are supported. So foot orthotics are the first three in this this diagram, which are more of just in-shoe inserts. They are really just supporting maybe the heel or the arch support. SMOs are super malleolar orthotics, or this pink one on the end here, and the red one, which are just go above the ankle, can help prevent some rotation at the foot and ankle, continue to support the arch. Ankle foot orthotics, or AFOs, are really commonly used can help manage with in-toeing and some rotation at the tibia or knee, and can help to prevent things like crouch gait and improve the energy in a child's walking pattern. KAFOs, seen here, are named as they go and support the knee joint as well as the ankle foot, and then HKFO going all the way up to the hip. In considering managing and support for a child with cerebral palsy, we're also working with vendors and therapists to think about equipment that a child will need through each stage of their life. Again, the medical therapy program through CCS, the therapists partner with the vendors and families to do in-home assessments, to think about what their child needs in their home and as well as in school to support the next step of life. As kids get to age 2, want to think about preparing for, if they're not already good standers, getting them into a standing frame, which this little girl here is seeing it, to support, to free up their hands, to give them a different perspective of the world, being more upright, which is appropriate at that age. As they also want to think about bath and shower equipment and safety in different areas and arenas of life. As kids get from change to 2 to 3 and they outgrow standard strollers or commercial strollers, you want to think about adaptive seating, whether that be by wheelchair or an adaptive stroller, which will provided ongoing support and improve mobility for longer distances for kids who are non-ambulatory. And then as kids get older and bigger, also want to think about how to support caregivers and safely transition a child who may not be safe to stand pivot transfer. And so this is a Hoyer lift in the top right corner. So all the while, as we continue to transition through each age group or each stage in life, we're still thinking about all of these guiding principles that were going on before, thinking about equipment, bracing, nutrition, spasticity management, but then also focusing on some particulars for school age, for kids with school age, for kids who have CP that are school age, including formal cognitive testing, IEP in the school, and talking to families about the importance of that, as 50% of children with cerebral palsy have intellectual disability, and still focusing on ways to keep them active and think about modalities for therapy. Those include vibrational therapy, which you can see here, which provide proprioceptive feedback, have some benefit for bone and joint health. Aqua therapy, which provides some weightlessness to allow for movement that a child might otherwise not be able to do if they weren't in water. Hippotherapy, which provides support for posture, has some benefits for pelvic and hip development. And then again, thinking about adaptive sports for cardiovascular fitness and just overall social engagement and quality of life. Moving from school age to think about adolescence and young adults, and then transitioning to adulthood, some particular issues that may come up in that time period. Still thinking about sports and activity, but also thinking about vocational training, whether the child is going to continue through high school towards a diploma track, or if they're going to transition to life skills, thinking about impaired drivers evaluations to help with that independence and knowing what adaptive driving may look like for them. And having conversations with family early and often about transition, including transition to new medical providers, to get to know them during the kind of transition period, as well as getting to understand, well, how much support does the child need? Do they need to be in a conservatorship? Do they need guardianship to help to maximize their support and independence, but also keep them safe? Next, we'll transition to thinking about specific interventions, including medications, injectables, and then move on to some surgical procedures that can be considered. When it comes to medications, specifically thinking about the management of spasticity for these children, medications can be grouped and classified into their mechanism of action. For many providers treating spasticity, I think a go-to medication is baclofen, which is a GABA agonist. It has an impact on the central nervous system, both in the brain and spinal cord. It's been used for over 40 years safely and to manage spasticity. Similar medications such as benzodiazepines, in particular Valium, are also commonly used as antispasmodics. And then I think for my guiding principle, I usually start with baclofen, and then if the tone isn't well controlled or well managed with baclofen, and I've gotten to a decent dose or a maxed out dose, think about changing or adding an adjunct, either with an alpha agonist like tizanidine or clonidine, or something like dantrolene, which has a different mechanism of action and may work synergistically. For most of these medications, the side effect that I warn families about are drowsiness, and although most of these medications are well tolerated, that drowsiness may happen as they get used to the medication, and then I have found that that fatigue or drowsiness wears off or wanes over time. Next, we'll talk about chemodenervation. And for that, the intervention is botulinum toxin. There are two main serotypes used for botulinum toxin injections, that being Botox and medication called Dysport. Botulinum toxin is an effective intervention for kids who have spasticity and hypertonicity in specific target muscles or target areas that you want to weaken. And the way the way Botox works is that it's toxin. It binds to the end of the nerve terminals and prevents the release of acetylcholine, the chemical messenger that tells muscles to contract. And so without that signal, it leads to muscle relaxation. The good thing about this medication is that it provides sustained weakness and decrease in tone, but the effect is that it usually onset is within 1 week of injection, with maximum or with peak effect around 2 to 3 weeks, and then find that the medication wanes somewhere around 3 months after the initial injection. And so one of the good things is that it provides several months of relief, but you also have to come back to get repeat injections, and you can't repeat those injections any more frequent than every 3 months. So it has to be further than 3 months out before you do another Botox injection. Now moving on to neurolysis. So for neurolysis, this is using alcohol injections as the medication for treatment. Here, the alcohol is instilled directly onto the nerve and causes direct injury to the nerve, causing the nerve muscle connection to be severed in a semi-permanent manner. This intervention is often used for children who, as you can see, have significant scissoring, and the target nerve is the obturator nerve for which innervates the hip adductors. What's nice about it is that there is an immediate onset. It is a low-cost medication, and because you're causing direct lysis or severing of the nerve, the body has to go through the entire peripheral nerve regrowth process, which takes somewhere around 6 months or longer to sprout and get the muscle reinnervated. The downside of this medication is that because instilling the alcohol causes pain, burning the nerves, a burning sensation, kids have to be under sedation of some sort before getting this treatment. And then if you want to target a pure motor nerve, which is why the obturator nerve for the hip adductors is a good target. If you get a sensory nerve or a sensory component to a nerve, you can have prolonged paresthesias or dysesthesias where the child has ongoing pain even after, even though the initial injury is over. For the next intervention we'll talk about is serial casting. And Dr. Livingston spoke a little bit about serial casting as well. Serial casting combines two interventions at once. It has the bracing support and alignment feature, as well as using the chemodenervation from botulinum toxin injections. And so the goal for serial casting is to, one common area of use is for children who are either toe walking or have ankle plantar flexion contractures. And you want to improve the range of motion to get the child back flat with their heel down. And so the way we achieve this is by injecting, if it's depending either one limb or two limbs, the gastrocs with both botulinum toxin, and then a week after that, the child will be casted in a comfortable range, but stretching the Achilles tendon and the gastrosoleus complex. And they'll be left in that for a week. At that week, at the end of that week, the cast will be cut. As you can see there, the skin will make sure that the skin integrity is good. If the skin integrity is good, you go repeat the casting process, increasing the angle of the tibia to foot, and repeat. So this child went through 1, 2, 3, 4 series of casting to get to a more neutral position of the foot and ankle, and hopefully have and then from the casting be put into AFOs to continue to support and prevent the habit to go back to walking on the toes. So Dr. Livingston certainly gave you guys an in-depth experience into orthopedic considerations for children with cerebral palsy. I will just go to say that, as she mentioned, hip disorders are very common in cerebral palsy. She also mentioned how the incidence of hip disorders increases as you increase in GMFCS levels. So as their function declines, you see more musculoskeletal issues, especially around the hip. And some important features that she mentioned are pain, range of motion, and the importance of hip surveillance. The Australians came up with a schema for hip surveillance, which was adopted by the Academy of CP and Developmental Medicine, which outlines what type, based on the functional level, how to do the screening. The principles here are guided by when children are GMFCS1 are very functional, the screening is less frequent and less common. First, when you first encounter the child at the first meeting, or at between 2 or 3 years of life, you should always get screening for every child with cerebral palsy of their hips and spine. Then you can, sorry, that's not true. For GMFCS1, you can just do physical exam and as monitoring. For 2 through 4, you should get 2 through 5. Sorry, you should get imaging upon initial presentation to you, and then or between the ages of 2 and 3, and then depending on physical exam findings, such as range of motion, pain, increased pelvic obliquity, you may need more frequent screening. And from that screening, as Dr. Livingston said, depending on what the migration index or percentage is, making referrals to orthopedic surgery for potential interventions, or physiatry if Botox may be a potential staying intervention for management. And then finally, looking at neurosurgical interventions. So as a physiatrist, I think about, or I try to help families and think about the potential interventions that may help their child with cerebral palsy, and refer respectively. And so There are two interventions in neurosurgical interventions that I'll commonly talk with families about. One is the intrathecal baclofen pump. And so neurosurgery, so the intrathecal baclofen pump is utilized for children with severe spasticity that either has failed more conservative therapy, and so you are using you're using this intervention to improve function and quality of life. From this diagram, you can see there's a pump that's placed in the fascia of the abdominal cavity, and then there's a tubing that delivers a catheter tubing that delivers medicine into the CSF within the spinal canal that bathes the spinal canal and the CNS in baclofen. So it's directly delivering baclofen to its target site. You're not, which is kind of cutting out the middleman of oral baclofen, which has to be absorbed through the blood and then get through the blood-brain barrier. And so for the baclofen pumps, you're using much lower doses of the medication. And you, with this programmer and this pump programmer, have the ability to adjust the amount of medication that the child is getting, offer boluses in times where their tone is increased, you have a little more freedom to titrate and tightly hone in on a specific dosage for of the medication. Neurosurgeons place the pump and do the neurosurgical procedure. A physiatrist or a neurosurgeon manages the pump medication delivery and things like that. There can be complications with the pump, complications with the tubing or catheter getting kinked. So there's there can be concerns for withdrawal and overdose with this medication since it's being delivered directly to the CNS itself. And then the final intervention, neurosurgical intervention that physiatrists may have a conversation with patients and families about is something called the selective dorsal rhizotomy. Again, this is the highest rung of interventions. It's as close to a curative procedure, I guess, for spasticity. It's a direct neurosurgical intervention where the neurosurgeons are select out the dorsal roots from the spinal cord. The dorsal roots are the roots that contain sensory input coming from the body back to the spinal cord. The inappropriate regulation of that sensory input is that leads to motor output is what is at play for spasticity. And we found that if you selectively cut the sensory input that's coming in, you get better motor control without risking paralysis or paresis. The best candidates are children with perhaps diplegic cerebral palsy who are pretty good walkers. They may be GMFCS 1, 2, or 3. And the target age range is somewhere between 4 and 11 years. You want the child to be able to engage with intensive physical therapy after undergoing this procedure, because we find that after dorsal roots, after they've had a selective dorsal rhizotomy, that there is always a component of weakness that is hidden by the spasticity or tone. And so we want to make sure that children are working towards regaining those skills, stretch that we're working on have a good stretching program to prevent contracture formation and work towards their prior functional abilities. And then I'll leave you with the Benioff Children's Hospital group, UCSF group. We are across both sides of the bay at Benioff Children's Hospital, Oakland, as well as SF in Mission Bay. And then some regional resources. So there's inpatient and outpatient, and the Peacock Center in particular over at Oakland, inpatient and outpatient for Mission Bay, Kaiser, Oakland, Valley Children's, and UC Davis / Shriners Hospital for inpatient and outpatient care as well. Thank you all for your time.